E eu convido o professor Hiroshi Mitsumoto, porque ele é a essência desse cuidado. Ele é o diretor da Associação Gherig. Essa associação é que nos ensina como cuidar dos indivíduos, e ele é neurologista e trabalha na própria Columbia University, essa universidade fantástica que se encontra em Nova York. Professor Hiroshi Mitsumoto, por favor.
Estou muito feliz de estar em São Paulo. Estou igualmente honrado em dar minha palestra sobre ela. I hope you understand, and this is the extent I can speak Portuguese. Any case, as you know, a lot of Japanese people in this country and a lot of Japanese words coming from Portuguese. For example, obrigado, arigato is Japanese thank you. So anyway, I'm so honored to be here, and also I heard so much wonderful presentation. This is really every effort to make best neuromuscular ALS care facilities. So I'd like to go next slide. So yesterday I had a wonderful tour about the neuromuscular center, particularly ALS centers. And again, this is a great teamwork of all people involved, and particularly these neuromuscular centers and also respiratory care centers, rehabilitation physical therapy centers. They are different places, but very close enough, and providing really wonderful care for the patient with this kind of disease. So today's title is ALS and Me. So I thought I should start a little bit my background. I graduated in 1968. Some of you was not born here, but yet I was graduated from medical school, Toho University, and after full medical training, I came to United States, Baltimore, Johns Hopkins Baltimore City Hospital. I did the internship, and then had wonderful neurology training at Case Western Reserve. This is the very famous doctor, Dr. Foley, and the famous doctor was Dr. Satoyoshi. So this gave me a foundation of neurology. And then I did some years after neuropathology training, I did a neuromuscular fellowship with Dr. Mansart and Dr. Mansart and Dr. Bradley. Dr. Bradley was my main mentor doing neuromuscular disease. So I was given to study wobbler mouse. By then, wobbler mouse was a model of ALS. So I did day in, day out, look at pathology of motor neuron degeneration, axonal degeneration, and really I worked so heavily with this model of ALS. You can see affected mouse is a smaller and a rough coat, and this grid was tilted. It cannot grip with the fingers. Determinate healthy was very normal, so that's what I studied as example of ALS. This motor neuron developed vacuolar degeneration, as you can see, vacuoles, and this turns out to be years later, this is FIG4 human disease. So this is indeed a counterpart of animal model in human is familial ALS FIG4 mutations. So I looked at animals, and if you look at the front pole, there's abnormalities, a little bit of curling, more curling, and the stage 3 is wrist curling and elbow curling. So we staged with this disease. we did a neurological examination, which is a very exciting examination. And you look at the grip strength, and then, running speed, and you time how fast the mouse can run. And also, if you look at the change of a pose, we did some clinical trials some years later, not after fellowship. So if you combine some neurotrophic factor, CNTF and BDNF, grade of pose change would not progress, disease arrested. However, control group treated with saline, disease progressed. 4 weeks treatment, most animals stage 3 or stage 4, as you can see. I'm not going into all detail. So if you look at the grip strength, top line is unchanged. Grip strength maintained with a combination of this CNTF, BDNF treatment, but no, untreated animals steadily getting worse, 6 weeks, no strength. But a middle one is 4 weeks treated and then withdraw medication after 4 weeks, again, grip strength deteriorated. So this is running time. Treated animals, yes, indeed, a little bit progressed, but untreated animals steadily getting worse, as you can see. And also resting activities, animal walking around in cage. So treated animals, BDNF, CNTF is steadily getting slowly increased, so more active. But untreated animals getting quieter and quieter, almost no movement. So if you look at the muscles, healthy animals on the left, and right side as treated animals, and untreated healthy animals, treated animals with right side, and middle one is untreated. So really a lot of atrophies, degenerative changes. So obviously change you can see. So if you even look at the number of axons, number of neurons, and the number of changes, treated animals are clearly much better than untreated animals, even if you look at the count of myelinated axons. So this study, CNTF and BDNF, was published in Science and was very exciting. So could it happen? Same thing happened in human patients. So we treated with CNTF and then BDNF and GDNF. Really nothing happened in human disease. Very big disappointment. Works in animals, but not in working in human patient. And also, we looked at the motor neuron changes, and strongly I felt pathologically abnormal neurons not necessarily lost function, but also normal neuron may not be completely functionally normal. The point is how we can move to healthier abnormal degenerating neuron to healthier conditions. That's what the really main goal when I was struggling and studying these animal models. So what we learned is by then we are talking about axonopathy and neuronopathies. There's a very good separation, but really in disease you cannot separate axon and neuron because they are continuations. Also, impaired neurofilament was a major cause of neuronal and axonal degenerations. And so as I said, morphologically, normal neuron may not be normal, but vacuolating neuron may not be functionally lost. So again, we need to move from abnormal neuron to healthier neurons. Moving to a little bit faster, then motor neuron undergoing neuronal degeneration must have a wide range of functional changes. So I studied for 2 years, and the more I studied this animal, and I thought I was not animal doctor. I'm really human doctor, so really I should devote to my time and effort to human disease. That's the reason I'm shifting from animal disease to human patient. So I moved to Cleveland Clinic and I did more patient care and establishing how we do providing multidisciplinary care by then. And again, you can see in the center, Dr. Roland was visiting professors and I was there nearly 15 years at Cleveland Clinic. Then, as Dr. Curry mentioned, I moved to Columbia in 1999 to succeed ALS effort of Dr. Roland. This was the Columbia University's number of faculties there again in the center, Dr. Roland. Dr. Peltier was the chairman by then. So I joined and established this clinic and did patient care and other scientific research. My effort is clinical trials to find better medication and also patient care and management. Established ALS multidisciplinary clinic, it was fundamentally important to provide the best care for the patient. Just one neurologist can do so little, but you need multiple health professionals such as nurse, physical therapist, occupational therapist, nutritionist, and social worker, and all those things needs to care. Just one neurologist cannot provide everything. So setting up care guidelines, and not all ALS care centers are the same in the United States. So bring up same high quality of care everywhere else in the United States, and also promoting excellence in end of life. Unfortunately, this is progressive, relentlessly moving to the end of life. So how we can improve end of life is very important issue. So important to educate the physician, not only physician, but also patient and caregivers, because the caregiver is essential to provide the best care at home. So educating and increasing awareness is so important. Then try to disease, developing biomarkers, and find out the cause of this disease. Still, we are making effort, but I think it's getting closer and closer. So clinical trials, I did so many different clinical trials. Red one, I participate. If you can see the color difference, blue one is we started from Columbia. And so I don't know how many, probably 20 or so for the past 20 years, did all kinds of clinical trials. So patient care and management, this is a very important, actually foundation of our neurology. We heard so much about Dr. Curry, how great he is, and providing care and putting science into the care and management. So that's what I have tried. So this is several years ago, our ALS clinic team members. We have a number of fellows and different discipline of doctors, psychologists, and pulmonary doctor, gastroenterologist, nurse, physical therapist, social worker, all those people, one after another, come to the patient and care. As you see, neuromuscular centers umbrella established is very similar, and I noticed such a well-organized care done at the São Paulo. So I'd like to show these pictures painted by one of a patient. His name is William Ross, and I saw him very shortly after I arrived at Columbia University. He had loss of function in both arms. His avid hobby was painting. He said, if I cannot paint, well, I have to live. So I said, so what? Why don't you paint with your mouth? So he was surprised. And then he trained with the rehabilitation, using mouthpiece to brush and painting with the mouth. And he painted 16 big pictures, his life. And he was tracheostomized. And you can see his picture in the center. He had a tracheostomy ventilator. And it's my wife and myself. You can see the picture behind the picture. He had painted the large pictures. One of the picture in our waiting areas. So important thing is to make their quality of life improved, maintained, along with the functions. That's what we have to provide for the patient with this kind of disease. So we did a lot of things. This is the teamwork. This is not just my work. A lot of specialists got together and developed patient management practice guidelines, how patients ought to be treated, and based on evidence. And for example, nutritional care, pulmonary care, and ventilators, all those cares. If you have a patient, if you find this kind of stage, what's the management? And you see this was published, first one 1999, second one 2009. So you can see how we provide equal, same level of improving the quality of life, quality of care, excuse me. So also promoting excellence in end-of-life care in ALS. ALS is still, unfortunately, progressive disease. At some point, there is an end of life, but how we can improve, maintain quality of life, and make the passage very acceptable and comfortable. That's what we had guidelines. And also published a number of books with the other team, and this is a book for patients and caregivers. I believe more knowledgeable, you can handle disease in better ways. So that's the reason we published. Last book was published a couple of years ago with Dr. Bedluck, was improving care towards the health professionals. So 3 books edited for patients and caregivers, and then 1 for health professional who is taking care of ALS. Also, we did a number of symposium. One is how to improve clinical trials. The other one is just a few years ago, we did clinical research. I believe very important clinical research in patients with ALS. Yes, I did so much mouse work, but the mouse and cells are important to supplement the cause of disease in patient. We have to do clinical research in patient and find out the cause of this disease. Also published a couple of books for health professional and what's the ALS all about in histories, pathogenesis, mechanisms, and care as well. So we don't have any biomarkers. We make diagnosis of ALS based on what the patient has kind of histories, examinations, eliminating other disease, and then that's the way we can make diagnosis. We need objective biomarkers. If we send out some tests and coming back, this is ALS, this is not ALS kind of diagnosis, much easier. We can start the treatment, in fact, much earlier. So extremely important to develop biomarkers. Now biomarker is studies everywhere in the United States and Europe, everywhere. So trying to develop. In fact, those lists I have, and I'm going to show you some of them. And also, extremely important to find the genes. More and more new genes are found. And those are covering maybe less than 10% of ALS patients, but new genes improve our understanding of disease mechanism. So again, we cannot just by yourself alone. You have to make a group. Collaboration is so important. So also we did several years ago to develop objective markers. By then we have no objective markers using magnetic resonance spectroscopy and transcranial magnetic stimulations, multi-unit estimate, multi-unit counting estimate, and also clinical findings, and those are combined to find what's the best by then to at least find out objective upper motor neuron signs. Upper motor neuron, as you know, of course, upper motor neuron brain, and I'm sure almost all of you are health professionals, so I don't have to explain what's upper motor neurons, but upper motor neurons just we can find by clinical examination. So we want to have objective markers. And we did all those studies, spending probably NIH grant money, $2 million, and then final result, as you see, Dr. Roland, myself, and a young doctors, Dr. Petro Kaufman, who is now very important officer at the NIH, NINDS, and also Dr. Gordon, and everyone carries hammers. By then, 2007, what we found is most helpful findings are clinical examination. Unfortunately, none of those neuroimaging, magnetic resonance spectroscopy, transcranial magnetic stimulation, MUNI, etc., was less than clinical examination. The clinical examination turns out to be best, but probably that's not the final. We have to develop still newer, better objective markers without any doubt. Oops, sorry. Ooh, I have no control. Can you go back a little bit? I didn't touch. I'm sorry. Maybe I should start from the end. Several slides back. I don't know, I'm sorry. That's fine, good. So also we did objective stress, oxidative stress biomarker in sporadic ALS and looking at the urinary biomarkers, which turns out to be very important. And also there is clearly oxidative stress. If you look at what we live, where you live, what kind of occupation, exposures, what kind of lifestyles, food, and psychological stress, what we do, everything final biological mechanism gives oxidative stress. So more you are exposed, anything negative, you have oxidative stress, but we have antioxidant process to counteract. And so if you have enough antioxidative process, there is no harm to the system. But if oxidative stress is more, certainly motor neuron eventually get more oxidative stress. That's our major hypothesis. So we did a study, we are doing studies, and multi-center studies, 16 centers in the United States, looking at more oxidative stress. And this is ongoing studies, just finished a couple of years ago, baseline, 355 patient. Now we are following, just finished the 2 years of follow-up. So this is a patient group, total of 355, and you can see the age and male-female ratio, what kind of ratio, distribution, and also educational background, and so forth. And you can see disease duration, ALSFRS, FVC, so you can see now baseline data, and we are now publishing a number of papers based on these studies, and we hope our hypothesis, more oxidatively stressed disease, faster and shorter survival. That's what the main goal of the studies, and we think we have that data in next 6 months. So based on these studies, we see creatinine becoming very important biomarkers at the baseline, lower, actually ALSFRS score is clearly linear relationship to higher ALS. So higher creatinine level gives a better ALSFRS score. The same thing is if you look at FVC, pulmonary capacities, again, linear relationship, better pulmonary function, creatinine level is better. So creatinine we have been using, I don't know how many decades, probably 50, 70 decades, and the creatinine, such an old biochemical substance, becoming very important biomarkers in large number of patients. We continue this program we called ALS Cosmos program into Arrest ALS. Arrest ALS is actually ATS-DL CDC risk factors environmental studies in ALS. this is going into entire United States. Everything done by the phone. Patients send the DNA by saliva specimen and urine specimen, and we get all information, epidemiological and psychological and cognitive function through all telephone interviews. Now we have about 40 patients just began this January, so we are trying to get at least 400 patients. Why we do such studies? Because we need a large number of genetic epidemiological correlation to find genetic and epidemiological cause of this disease. So what have I learned? Well, ALS is still the most intractable disease, but no disease is ever impossible. I think it's getting closer and closer. We're providing very good care to the patient, but certainly we can do better and we can stop this disease at some point, not too far. And continue the progress in practice guidelines, clinical trial guidelines, expanded the genetic causes, plausible biomarkers, and increasing understanding of environmental factors. I think we are getting closer and closer, as I said. And then Americans said the bases are loaded, as you know in the baseball, and I'm sure the Brazilian says setting up a final kick for the winning goal. So I think we are getting close to that point. So just I'd like to acknowledge this is ALS PLS Cosmos Studies Group and site investigators, and also I'd like to thank to all Columbia Group, Eleanor Gherig ALS Centers, Columbia University investigators, and also investigators from other institutions. That's what collaboration is the key. I think we heard this morning so much important officers, professors talked about, of course, Dr. Curry, but I think it's teamwork to make this is so crucial. And just I'd like to show the slides, the funding agencies, I hope. So NIH and MDA, ALS associations and CDC, and all those groups are funding research. I think we are making effort. And I heard Dr. Curry said now 16 or 17 years after he started a multidisciplinary clinic. And he said now this group is adolescent. I think he's so modest. And I think it's becoming much more mature. And I believe Brazilian study group, yes, already a member of Alliance, ALS Alliance, but I think it should contribute to get to more science, clinical management to everywhere else, United States, and participate in ALS symposium. That's what I think is so important. I'm really impressed what you're doing in Brazil. So thank you very much for this opportunity to give me to talk about what we did, what I did for ALS. Thank you very much.